Research studies show that multiple sclerosis is misdiagnosed 10% of the time or more. In this video, I will show you some of the common neurological conditions that are commonly misdiagnosed as multiple sclerosis, and I will show some of their characteristic MRI findings. Let's have some fun. I'll show you some pictures, but first, let's take a look at a typical multiple sclerosis MRI. This is an interesting study of someone with MS who underwent an MRI every 2 weeks, and the images were superimposed on top of each other to create a movie, and you can see the lesions coming and going. Believe it or not, this patient was completely stable, reporting absolutely no change in symptoms during the study. But what are typical multiple sclerosis lesions? They tend to be bright on T2, dark on T1. They don't have a lot of mass effect. They're often ovoid in shape, and they're well demarcated between normal and abnormal tissue. Sometimes they're in specific areas around the ventricles, forming what are known as Dawson's fingers. And sometimes they line up in the corpus callosum, causing a so-called picket fence sign. They're in specific areas such as next to the cortex at the very surface of the brain, in the brainstem and cerebellum. And when they involve the spine, they're often very short and towards the back of the spine. And in pathological sections and on 7 Tesla MRI, we can see that they're perivenous around the veins. And when they take up contrast, there's often an open ring of enhancement. A closed ring is seen in other diseases, such as abscesses. And often they take up the dye or enhance, but only briefly, and the dye often fades if we do a follow-up MRI scan, as opposed to other diseases. Let's take a look at some cases. This person had headaches, confusion, and also had a history of stroke and intracranial hemorrhage. The erythrocyte sedimentation rate was elevated. And you can see these lesions that are sort of radiating away from the center of the brain. That's very characteristic. This is a catheter angiogram of the internal carotid artery. And you look at the arrow, you can see that the blood vessels dilate and constrict, forming a beads on a string sign. This is typical of central nervous system vasculitis. And it can be caused by what is known as primary central nervous system angiitis, or sometimes secondary to other systemic autoimmune diseases. It's often treated with immunosuppressant medications. This is a 32-year-old veterinarian with right eye vision loss. Superficially, you might think that this is due to optic neuritis, but if you look at the center of the retinal photo, you can see some cholesterol deposits around the macula. This is known as a macular star. And this is characteristic of chorioretinitis. And this is, in this particular case, this is due to cat scratch disease. And the treatment is antibiotics with doxycycline and rifampin. This is a 59-year-old with progressive leg weakness and pain. The MRI scan showed this thoracic lesion, which avidly took up the contrast dye. Further evaluation showed that there were abnormal lymph nodes in the hilar area in the mid-chest around the heart and the bronchi, and they avidly appeared active on PET scan. The diagnosis is neuro-sarcoidosis, or neurological manifestations of sarcoidosis, in this case confirmed by a biopsy, again treated with immunosuppressant medications. This is a 33-year-old who had confusion, slurred speech, and tingling of the arm and weakness. There was no prior illness. MRI showed these puffy lesions, including, if you look at the left side of the image, a so-called C-fiber lesion that actually looks quite typical of multiple sclerosis. However, follow-up MRI 1 month after IV solumedrol showed complete resolution of the lesions, and this patient did not go on to have further episodes of neurological symptoms. This was acute disseminated encephalomyelitis, or ADEM, a uniphasic autoimmune disease of the nervous system, sometimes triggered by a vaccine or infection, not a chronic disease like multiple sclerosis. This is an 18-year-old woman with hearing and vision problems. Now, if you look at the arrows, they're pointing to very characteristic lesions that are T1 dark and circular in the corpus callosum. You might superficially believe that these could be corpus callosum lesions seen in multiple sclerosis, but they tend to be rounder and not involving the whole width of the corpus callosum. Also, on more careful examination, you may realize that her visual difficulty is actually due to vasculitis of the eye rather than due to optic neuritis. Indeed, this woman had SUSAC disease, which is a rare autoimmune disease of young women involving anti-epithelial antibodies. It's very poorly understood, and it often involves very young patients around age 18. The median age of onset of multiple sclerosis is 30. This is another case, a 33-year-old woman who had clumsiness of movements, ataxia. She also had chronic gastrointestinal complaints, but her symptoms improved after a special diet. If you look at the MRI to the right, you can see abnormalities in the brainstem and cerebellum consistent with this disease, which is celiac disease, which rarely involves the cerebrum, in this case called Gluten's ataxia, and it is treated with a gluten-free diet. This is a 48-year-old woman with insidious onset cognitive changes. She also had a family history of a similar condition and early dementia. She also reported complex migraines or migraines associated with other neurological symptoms such as numbness or weakness or slurred speech. If you look at this MRI, you'll see confluent white matter changes radiating throughout the temporal lobes that are very symmetrical and extending into the anterior temporal lobes. This is not characteristic of multiple sclerosis, but quite commonly misdiagnosed as multiple sclerosis. This is CADASIL, cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy. This is a genetic disease that causes progressive damage to the endothelium of blood vessels and progressive strokes. The mutation is on the gene Notch3 on chromosome 19. This is a patient with progressive cognitive decline and weakness and numbness on the left side. You can see that there are multiple lesions that take up the contrast dye avidly, and there is an obvious mass effect where the right side of the brain appears to be pushed to the left side. This is actually a tumor, a very aggressive brain tumor called a GBM, or multifocal glioblastoma glioblastoma multiforme is GBM. I've actually seen one case in my career of a young woman with a GBM mimicking multiple sclerosis, and it actually really did look like MS on the initial MRI. This is a 51-year-old male with diabetes insipidus, and he had difficulty swallowing, double vision, and numbness over the body. This MRI shows a patchy abnormality in the pons. More data on the next slide. This is a scan of the bones, which showed abnormal increased uptake in the long bones. This is actually a biopsy of the bones, and you're looking at a CD68 stain. This is a stain to look for histiocytes, and you can see the entire slide is covered with abnormal histiocytes. This is Erdheim-Chester disease. This patient had neurological manifestations of a cancer of the known as histiocytosis X. Erdheim-Chester disease actually refers to the abnormal invasion of the long bones by the cancer. And it's associated with other changes like fatty absorption within the eyelids, sometimes with orbital and pituitary involvement, and it's treated with anti-cancer therapy. This is a 66-year-old man with uncontrolled high blood pressure who rapidly was developing cognitive changes, and you could see extensive white matter lesions. Is this multiple sclerosis with confluent lesions of the white matter? Absolutely not. This is Binswanger's disease, or rapidly progressive cognitive impairment due to uncontrolled high blood pressure. It's now rare, but it used to be quite common before we had medications to treat high blood pressure. You can see the white matter distribution is very different. The lesions are patchier and indistinct. And if you look closely, they involve certain areas such as the external capsule, which are not commonly affected by multiple sclerosis. Is this a tumor? Looking closely at this lesion on the left side of the brain, there is not a lot of mass effect relative to the size. Also, there appear to be some areas that are unaffected, known as onion skinning in appearance. And this type of mass tends to spread outward, but spare certain areas. It's a very characteristic of this disease, which is Balo's concentric sclerosis, or a form of tumefactive multiple sclerosis. Believe it or not, there's good evidence that this disease is highly connected to multiple sclerosis and often responds to the same treatments. This is a chronic alcoholic who is now developing various neurological deficits. This MRI scan shows changes within the corpus callosum that are extensive and confluent, not typical of multiple sclerosis. This is a rare condition known as Markia-Fava-Bignami disease, and it's believed to be caused by thiamine deficiency. And for whatever reason, some people get this manifestation rather than Wernicke's encephalopathy or Korsakoff syndrome. This is treated with thiamine replacement, although some of the deficits can be permanent. This is a 26-year-old woman with genital and oral ulcers that do not seem to be caused by herpes. She also had aseptic meningitis and what is known as a positive skin pathology test. That's when you put a needle in the skin and just spontaneously a lot of inflammation develops in response to that. Now, the lesions on the MRI are a bit unusual, not necessarily indicative of a specific condition, but if you put it all together, you should be able to confirm that this is neurological manifestations of Behçet's disease, which more commonly causes the ulcers and skin lesions, but sometimes can have neurological manifestations. This is more common in the Middle East, although I have seen a few cases in the United States. This is a patient with vertigo, double vision, and on the MRI you can see these speckled enhancing lesions appearing very unusual. However, this patient had complete resolution of all symptoms and MRI findings after being given high doses of steroids. The appearance of this MRI is very characteristic and in fact pathognomonic of this disease, which is Klippers. This is chronic lymphocytic inflammation with pontine perivascular enhancement responsive to steroids, Klippers. It's a very rare and poorly understood autoimmune disease, though we're seeing an increased number of case reports. I believe I've seen exactly one case in my career. This is a 64-year-old man with slow onset confusion, difficulty speaking, and psychiatric changes. The MRI scan shows subtle brightness in the temporal lobes. There was a consideration that this could be herpes encephalitis, but in spinal tap showed that he does not have herpes encephalitis. He in fact has autoimmune limbic encephalitis. This can be associated with a cancer or paraneoplastic, or it can be simply autoimmune. And there are various antibodies that can be associated with this particular syndrome, autoimmune encephalitis. It's treated with immunosuppressants. This is a 32-year-old Japanese woman with optic neuritis of both eyes and weakness of the extremities. MRI scan showed a lengthy enhancing lesion in the cervical spine, looking at the left image. Now, this is not typical of multiple sclerosis. In multiple sclerosis, the lesions in the spine tend to be short and posterior. This is a long and central lesion, what is known as longitudinally extensive transverse myelitis. This is neuromyelitis optica, formerly known as Devick's disease, and in about 70% of cases, we can confirm the diagnosis with a blood test for the anti-aquaporin 4 antibody. This is a 35-year-old woman who is pregnant with preeclampsia. Preeclampsia is basically high blood pressure and swelling of the ankles, and it's a complication of late pregnancy. But she started developing vision loss and headaches, and her MRI scan showed these patchy lesions towards the back of the brain. This is PRESS, posterior reversible encephalopathy syndrome. It's believed to be due to decompensation of the blood vessels in their brain and leakiness of the blood vessels causing swelling within the brain. And it's associated with various causes, most commonly preeclampsia and eclampsia and high blood pressure, but also certain medications and low magnesium levels. This would be treated with a delivery of the fetus. This is a 66-year-old male with diabetes, high blood pressure, end-stage renal disease, in other words, multiple vascular risk factors, who developed sudden onset weakness and numbness of the legs. However, vibration sensation of the legs was spared. Now, these MRI scans may be difficult to see, but if you look closely, there is diffusion restriction within the spinal cord. And so this is actually a stroke of the spinal cord. And sometimes it can be spontaneous, or sometimes it can be due to certain types of interventions on the aorta or a bronchial angiogram. And you can diagnose it with DWI and ADC images of the spine, which are not routinely done. The vibration sensation is spared because the infarct typically occurs of the anterior 2/3 of the spine that is not controlling vibration. The posterior columns are spared. This patient had very chronic burning in the legs for years and decreased pinprick sensation in the hands, and was in fact burning herself on accident because she couldn't feel her hands very well. If you look at the MRIs, you'll see there's a T1 dark and T2 bright lesion in the center of the spine. Is this a multiple sclerosis lesion? If you look very closely, you'll see that it actually follows cerebrospinal fluid on every sequence because the lesion is cerebrospinal fluid. And what this is enlargement of the central canal, which is normally present, known as hydromyelia. It's not syringomyelia, which would technically be an area other than the central canal replaced with cerebrospinal fluid. This is a patient with a history of gastric bypass surgery with slow onset weakness and cognitive changes. She also had anemia with large red blood cells. If you look at the MRI of the spine, towards the back of the spine, there's an extensive white lesion that looks very linear. And if you looked on axial images, you would see that it involves both the posterior and lateral columns of the spine, known as subacute combined degeneration. And this is, in this case, due to B12 deficiency due to the history of gastric bypass, but you can get an exactly similar disease with copper deficiency, or zinc toxicity, which interferes with copper absorption, or rarely with nitrous oxide abuse. This is a 3-year-old boy with a history of, quote, encephalitis, who then recovered, who now has lethargy and confusion after an upper respiratory tract infection. He improved when protein in the diet was restricted. Now, if you look at the MRI, you see very symmetrical lesions in the basal ganglia and thalamus, not typical of multiple sclerosis. Indeed, these lesions are typical of metabolic disease. Now, you would never be able to guess the disease just based on the pictures, but this particular patient had maple syrup urine disease, which is a genetic defect in metabolism of branch-chain amino acids. This is an 8-year-old girl with short stature, hearing loss, and an eye disorder known as retinitis pigmentosa. She also had Parkinsonian features, in other words, gait and other physical changes resembling Parkinson's disease. If you look at the MRI, you can see that there are asymmetrical lesions in the caudate and putamen, and some of them appear to be diffusion restricting. These are highly characteristic findings of mitochondrial disease. And if you look at this MR spectroscopy of the abnormal area, you can see a lactate doublet. You see 2 peaks in the lactate area instead of 1, which is characteristic of this disease, Lee's disease, which is a genetic mitochondrial disease. This patient had weakness of the extremities and confusion after receiving 3% saline, in other words, a very concentrated saline solution, because she had low blood sodium. In other words, the blood sodium was rapidly corrected. You can see that there are white matter changes within the pons, but also in other areas like the temporal lobes. The history should give away that this is central pontine myelinolysis, in this case with extrapontine manifestations. This occurs with very rapid correction of low sodium, and that's why sodium should be corrected slowly and carefully while checking blood tests usually every 6 hours. This is a 45-year-old woman with chronic lower extremity burning pain, now developing numbness and weakness. You can see on the MRI of the spine, there's a large enhancing area in the center of the spine, but her deficits on exam are extremely minimal. And if you look closely, you can see that surrounding the enhancing area, there seems to be an enlargement of the central canal around it. And the reason for that is because it is inside of the central canal, pushing it open. This is not transverse myelitis. This is actually a tumor. In this case, an ependymoma, and she also has secondary hydromyelia, which is enlargement of the central canal. These tumors are benign, but sometimes they can grow slowly and cause problems and even require surgery. Sometimes people can live years or even decades without operating on them. Just based on the image, if you look at this MRI, you can see in the pons there's a lesion that is T2 bright. But if you look at the T2 flare, you can see that it's actually dark. So what is this? Is this a multiple sclerosis lesion? No, this is a stroke, a lacunar infarct of the pons. Demyelinating lesions associated with MS are very rarely suppressed by flare, particularly if they're small. This is a 34-year-old man with gradually worsening leg stiffness and weakness. His mother and maternal grandfather had a very similar disease. Exam surprisingly shows that he's not that weak, but he's very stiff in the legs. MRI scan shows a linear lesion, which is actually a dilated and posterior central canal. And if you look closely, you can see that the spinal cord is atrophied, but there are no lesions typical of multiple sclerosis. And that's because what he actually has is hereditary spastic paraplegia. In this case, an autosomal dominant form, but there are various genetic etiologies. And some of them are associated with brain malformations, such as atrophy of the brain and changes in the corpus callosum. This is a 44-year-old man with AIDS with a very low CD4 count of only 17, a very weak immune system. And he developed gradual onset memory loss. And his MRI showed these patchy lesions kind of filling up the gyri in different areas. What he has is progressive multifocal leukoencephalopathy, PML, and usually the lesions in AIDS do not take up the contrast dye. And the way to treat this in this case is just to start antiviral medication. And there's also some evidence that the antidepressant mirtazapine, which is Remeron, is effective against the virus in vitro. So this has been attempted in PML. This is a 32-year-old man with ophthalmoplegia, which is paralysis of eye movements. He also had clumsiness of gait, ataxia, and drowsiness and confusion. The MRI scan showed these symmetrical lesions that take up the contrast dye in the midbrain. And he had positive anti-GQ1 antibodies. Now, these antibodies are typically associated with Miller-Fisher variant Guillain-Barré syndrome, but they're also associated with this very closely linked disease, which is Bickerstaff's encephalitis. And this is quite rare, but it is associated with these antibodies, and it often responds to immunosuppressants. I hope you enjoyed the presentation, and if you have any questions, please post in the comments below, and please subscribe for a video about MS every Wednesday. Thank you.